Yeah. Okay, welcome to the Spine Conference. So today's, I like to do relevant cases because it makes life, good morning. It makes life fun and interesting and keeps things up to date. So today's case will be a metastatic endometrial adenocarcinoma to the spine.
Mm.
And we'll start with the history. So this is not the patient but herself, but sort of similar. She's 64, and just so you know, just interrupt me if anybody has any questions whatsoever. The 64-year-old woman with her chief complaint was bilateral lower extremity pain. So her history was 2 to 3 months prior to presentation, she had flank pain. And she went to the emergency room at Hartford for flank pain. She was in the ER January 24th. She had urinary frequency, and they did a diagnosis of hydrouteronephrosis. So she had a history of uterine carcinoma, endometrial carcinoma, which was treated with radiation. And they inserted a nephrostomy tube, and they also did a cystoscopy and a double J stent February 28, 2017. But she kept complaining of flank pain, which everybody felt was due to hydronephrosis, which kind of makes sense. But the flank pain never got better. Her pain became severe. Her primary care physician ordered some x-rays, and then due to the severity of her pain symptoms, she went back to the emergency room March 5th. And at that time, they did a CAT scan, which showed lytic lesions in T7, T9, T12, and the left hip, and we'll go over all those images. So past medical history, she had a complete hysterectomy at university a year ago, stage 2 uterine carcinoma, treated with 30 radiation treatments, 27 beam, 3 vaginal, and she was basically disease-free for the last year. Her other past medical history, nothing severe: cholecystectomy, depression, hypertension, nephrolithiasis, hydronephrosis. She takes Depakote, Lortab, Bactrim. She's a clerical worker. Her on exam, there's a couple things on exam. First is she won't walk, and that's a big problem. She says her legs are weak diffusely, and she has extreme left hip, lower extremity pain, like diffuse left lower extremity pain. So any questions so far about the exam? So she doesn't walk, she can't get out of bed, she does have motor strength. On the left it's 2 out of 5, but she has pain. On the right it's 5 out of 5. So when someone has pain, it's hard to say if this is from a neurological dysfunction, say compression of a nerve root or spinal cord, or if it's just from pain. It just hurts and you can't move. So it's hard as a doctor to know which one it is. Okay. So this just shows she had hydronephrosis, and she had a stent placed. And this is the CAT scan in the emergency room. And Aaron, just to keep you awake, show everybody what you see. Aaron? Yeah.
Is that T12?
Yeah, T12.
So T12 obviously has an abnormality.
Yeah.
Even L5 looks.
Maybe L5. How about higher than T12? See the other one?
Yeah, T9
in the vertebral
T7.
body, T7. How about in the axial cuts?
Axial cuts, you can see.
Okay. So what are you have any concerns, worries? Like, what are your thoughts if you see this?
Something.
Some maybe metastatic process, and the question is in the report was no spinal cord compression. So can you make a diagnosis of spinal cord compression?
Well, but you can't really see.
Yeah, so you need an MRI scan to know that for sure, right? And so the CAT scan is just the best test we have. That's very quick in the emergency room. So in my mind, so any questions so far? So in my mind, this is probably a metastatic process, but we don't know where it's coming. Well, we know where it's coming from, but let's say we didn't know where it's coming from. We're not 100% sure it's coming from her adenocarcinoma, but most likely. But a more common problem is a skeletal metastasis of unknown origin. So we see this all the time. It's a metastatic process to the spine. We don't know where it's coming from. It's very important for us to know where it's coming from. So prior to any type of surgery, the patient needs a workup. And the workup is blood work, history and physical, CAT scan, chest, abdomen, pelvis, and a bone scan. And the reasons why we need all these tests are we have to rule out a primary sarcoma of bone, which is extremely rare, but if that is the case, it needs to be resected with a margin. So we have to make sure that that's not what it is. We may find another area to biopsy, which is easier than the spine. If it's renal cell and we do surgery, they need preoperative embolization. Maybe we can make a diagnosis without a biopsy, and also it helps the pathologist if they know if they have more history. What can you? I mean, is that the case, Dixon? Like, how does it help you?
Well, just obviously the history of previous tumors helps a lot because then you kind of know, common things are common, and so you want to give somebody one cancer that's metastasized versus two separate cancers. So if you know that they have a prior history, especially one that has a tendency to metastasize to bone, then it really helps you know kind of what you're going for, what you're looking for. You can already start to narrow down the field, and also if you if you have again, the images kind of help you know, that it's not just one isolated lesion, that you've got several lesions. So again, that speaks more to metastasis than like a sarcoma primary.
Okay, so what's the test? The test is calcium. I get a calcium on everybody. Just I have a personal story. One of my very close friends is an oncologist, and he said his mother died from metastatic carcinoma, from hypercalcemia from metastatic carcinoma. So, which is kind of ironic. Maybe that's why he went into oncology. But that's why everybody gets a calcium, just to make sure they're not hypercalcemic. And then serum protein electrophoresis to rule out multiple myeloma, PSA for men, prostate. I get a SED rate just to follow, because I'm an orthopedic surgeon, we use SED rate to follow diseases. A CRP, maybe liver function tests, maybe CEA. So most likely this is a bone metastasis from carcinoma. So this is just a diagram of bone mets. And the most common decade, unfortunately for me, is my decade, 50 to 60. And what bones are there? I highlighted the most common ones. So the spine, this is out of, I don't know how many, I think it's like 2,000 or something, but the spine, the pelvis, the proximal femur, and ribs. And why those areas? It's because those areas have, I think, rich cancellous bone, and the cells tend to slow down in the capillaries of those areas, and that's why you get mets there. And you also get infections there in children. So it's a common place for that to happen. So where do mets go? They go to liver, lung, bone, and it's a process where the cells have to grow. Then the cells have to create blood vessels, and then they have to leave the primary site and go into the blood vessels, and then go into the bone to see the proximal femur. That's where the vessels slow down and the tumor can come out, and then it has to grow. So all these things have to happen for metastasis. And this is just the venous system, and the spine has a very rich venous system. And you know this, Aaron, when we take a rongeur and we take a bite out of the vertebral body, so we can hit a vein sometimes. It bleeds a tremendous amount. So it's got a very rich flow of blood. And so does the pelvis. There's a lot of cancellous bone. And just the Batson's plexus is basically, this man did a study, he's from University of Pennsylvania, where he stuck an IV into the dorsal vein of a penis and pushed dye. And it just went up the normal inferior vena cava into the liver and up, which is normal. But if he took the baboon, which he was doing this on a baboon, and pushed on the abdomen, instead of going through the IVCs, it went through the spine. So that's why we get all these tumors in the spine and not in the liver. In autopsy, and if I say something wrong, Dixon, please correct me, okay?
You're 100% so far.
Okay. So if you so in autopsy studies, 70% of patients with cancer have involvement of the bones, and most common are breast, prostate, lung, renal, hematopoietic, and thyroid. And this is just a couple recent studies, data from 2015 for cancer incidence in the United States, more men than women. And for men, it's just very prostate. For women, it's breast. And you see our case, the uterus is it's only 7% for women. And this just the incidence of cancer has been slightly decreasing. Dixon, do you know why there was a spike in 1994?
A spike in 1990
See
cancer
that?
incidence rates.
Isn't that interesting, isn't it? I don't know if that's from diagnosis, like we were just diagnosing cases.
One thing that comes to mind is there was an increase in smoking, like in the 40s and 50s, and so those patients, there was a decrease in smoking starting like in the about 1970, 75. But those people that really started smoking, and then the high incident, the high number of people, I guess all this is per 100,000. I'm thinking of lung cancers, just in terms of kind of like that's the age that they kind of spiked up in terms of lung cancer.
That makes
And
sense.
obviously, this was also the time that you're really, really starting to see a lot more breast cancer just from, from better observation, better ultrasound, mammograms, et cetera, et cetera. So it may not have been a true increase as opposed to kind of a diagnostic increase.
Mhm.
We got really good at diagnosing cancer in a lot of different sites around that time. But then why it's come down, again, maybe that's the decrease in smoking, and we found other things, that may be causing cancer, but that's just an idea. But
Or early,
I've never really seen that chart though like that.
it's interesting.
The spike is on men in particular, so is it something with prostate diagnosis? 'Cause the
Smoking,
women
yeah.
was pretty
Yeah.
That's
flat. Men and
we started
women.
doing a lot of ultrasound guided prostate biopsies around that time. So again,
Mhm.
and people, if you just ignore prostate cancer, most people don't die of prostate cancer. So we're probably just identifying these low grade, smoldering prostate cancers. Um,
Mhm.
better diagnosis of lung cancer. It probably has more to do with better diagnosis.
Mhm.
But then the decrease is kind of interesting too.
Okay, so just lifetime probability for men to get cancer, it's 50% for all sites. And well, again, most common is prostate. And for women, it's 33%, most common breast. And just for metastasis, most common malignancy goes to bone, and spine's the most common area to get a metastasis. 5 to 10% of patients with cancer get a spinal metastasis. And it's usually the thoracic spine. Why? Maybe the rich plexus, maybe there's just more bone there because we have 12 of those, by the way we just classify it.
Hmm.
Um, and the most common primary is unknown. So just we went over these imagings: plain X-ray, bone scan, CAT scan, chest, abdomen, pelvis, MRI, PET scan. The bone scan, I like it because it shows me where everything is. So we can tell the patient you have 2 lesions in the rib, 1 in the proximal humerus, 1 in the pelvis. We can easily access this one for a biopsy. So why don't we just do the easiest one? Um, the CAT scan is helpful in spine, especially because you know how much of the cortex is gone. So it gives you a lot of information. If the cortex is gone, it changes the way you do the surgery, and you'll be less likely, say, to insert cement if the cortex is gone, because you know the cement will flow into the spinal canal more easily. So it gives a lot of information. Okay, so any questions so far? Okay, so we're back to our case. So she never got an X-ray. She just got a CAT scan. So we got an X-ray. And Aaron, can you show maybe we're T12 slightly? Yeah, so maybe loose ends. Very difficult to see that. But the majority of the structural integrity is pretty good. So the CAT scan showed a lesion of the hip. So I got an X-ray and show us the left lesion of the lesser troch. See the lesser troch a little farther down right there, yeah.
Mm.
So it's almost about to come off, which that's not a big deal if you lose your lesser troch, if it pulls off, the tendon pulls off. But the problem is if you had a proximal femur fracture, um, it's more difficult to fix it if it's broken than if it's intact. And just so you know, in orthopedics, lesser trochanteric lesions are very high risk for fracture. So basically, you almost always need to fix them. But we'll go over when you need to fix them. So the MRI. So Aaron, show everyone what you see. So the patient, I said the first thing is we need to get an MRI to see if the spinal cord's compressed. So we ordered the MRI. Aaron, what do you see on the?
So you can see that T12 here has some
Tumor?
Yeah.
Yeah.
Assumption of tumor.
Uh-huh.
You can see bulging discs, L2, L3, L4. 3, 4, 4, 5.
Okay. All right, that's good enough.
Yeah.
And how about in the fat suppression
On
images?
fat suppression, you can see all of
Mm.
T12 lines up, all of the tumor,
Mm.
and compromise the canal.
How about the axial cuts?
Um,
Show everyone where the spinal cord is.
So here's the
Mhm.
spinal cord. You can see here the tumor.
And it looks like it's emanating from the pedicle, doesn't it? Like the back of the vertebral body going into the pedicle, going to
Yeah.
the posterior elements, and then compressing the spinal cord over. And on the bottom right one, point to where the spinal cord is.
Oh, it should be right here.
Where is it? You can see it.
Right here.
It's compressed up against the pedicle. Find the pedicle. There, it's right
Oh,
up
it's all
against
the
it.
way
See
right-
that?
that's
Yeah,
over there?
yeah. It's all the way there.
Wow.
So
So this
the-
is part of tumor?
That's all tumor. So I think that's all tumor. Yeah. And so here's lower down. So you see how the cauda equina is still to the left, even though there's no tumor? Why is that?
Because it's compressed higher.
It's compressed higher up, right? So this is just my cartoon. If you have compression in one area and then you see the axial cuts, the spinal cord stays deviated due to this compression above and below.
Mm.
So I don't know, this is kind of just fun. I think of these things because sometimes even with big disc herniations, the spinal cord shows a deformity below the big disc herniation. It's because of this. It's just a mechanical thing. So when you do surgery, so there was a great study in 2005 based in the University of Kentucky on spinal cord compression from metastatic disease. And this may be a little bit boring, but it's very important to know this, is they did a randomized double-blind study where they took 100 patients with solid tumors with spinal cord compression. So spinal cord means either cervical or thoracic spine. And then they randomized them. One group just got radiation, and the other group got immediate surgery and radiation. And at the time, it wasn't quite clear who needs surgery. Like in the 80s or 90s, everyone just got radiation. No one got surgery. And when do you do it and why do you do it and which one's better? So this was an incredible study, I think. It's a landmark study. And the entry criteria was no previous radiation, expected survival greater than 3 months, adults, and they excluded very radiosensitive tumors like leukemia, multiple myeloma, germ cell tumors, lymphoma. And primary spinal tumors are excluded because those need to be removed with the margin. So what happens? The people that had immediate surgery did better in almost every single criteria. So if you just see post-op who walked, 84% of the patients that had surgery walked, both short-term and long-term, versus 57% of radiation. So they walked a lot longer. And then this is just how long did you walk? The surgery patients walked for 1,000 days. You can see that almost a lot of them did. So you walk for a lot longer. How about the people who didn't walk when they first came in? They were non-ambulatory because from the tumor. The surgical patients, 62% of those people went on to walk versus only 19 for radiation. So if you come in paralyzed, there's a much higher probability you will walk if you have surgery. And another thing is opiate use. The surgical patients got a lot less opium than the radiation. So use that as a surrogate for pain. The surgical patients had less pain. And mortality was better, and the strength was improved. And also there was a crossover. So people had radiation, but they didn't do well, so they crossed over to the surgical site. Those people didn't do as well. The surgical complication rate was 40%. So just from the radiation, it altered the soft tissues, so they didn't do as well. So immediate surgery is the best treatment. So the conclusion is for these patients with spinal cord compression from metastatic disease and not tumors that are obviously radiosensitive, they do a lot better with immediate surgery. So
The numbers are small. Has that been repeated anywhere? Or is it now current practice?
you know, it was the best designed study ever.
The numbers are small, though. That's the problem.
Yeah, it is. But it was randomized.
Yeah.
You know why the reason why the numbers are small is they stopped the study because it was so clear how better the surgical patients did.
Okay.
And I'm not sure if it has been. I have to look into that. It's been. I'm gonna have to look into if it's been repeated.
So current practice now is to do surgery?
Sir, yeah, no question.
Okay.
As a result of this study, really, from 2005.
Ca-
Yeah.
Are there There is a review article in the current New England Journal of Medicine on spinal cord compression.
Really?
I haven't read it yet, yes, but it's a
Okay,
major
well,
article.
now you gave me some homework. I'm going to have to read it.
Yeah.
Okay.
I
Well,
think April 6th, April the 6th issue.
okay, well, I'm going to read it, and next month we'll go over it. How's that?
That's good.
Okay. But I'm a little worried because anything in the New England Journal of Medicine means surgery is not a good idea. But, well, do you know that?
I didn't know that.
Right, David, is that a rule of surgeons? Anything New England Journal of Medicine says, no surgery is necessary, right?
Apparently, yeah.
Mostly internist, huh? Internist on the editorial board, huh?
All right, so back to our case. So this is a metastatic tumor with spinal cord compression with symptoms. Patient, I didn't go over this, but is a strong, healthy woman. Before this, she was walking very with it. So she needs the best treatment for her is surgery. So I performed the surgery. Just the basic premise: 4 screws above and 4 screws below hold the spine very well. And the tumor was on the spinal cord. And Aaron, do you remember this case?
Mm-hmm.
How would you explain how did the tumor look like, grossly? How was the case? Do you remember it? The lamina, how was the lamina? Was it hard as a rock?
It was, very medical term, mushy.
Yeah,
The bone was,
very
not-
soft.
yeah,
It was eroded, right?
right.
And then how about the tumor on the spinal cord?
It was very vascular and very attached.
Yeah, yeah. So a lot of blood vessels, which is hard because you're trying to control blood, and yet you don't want to damage the spinal cord. And it was very attached, so you had to peel. Remember, we were peeling it off, and it was stuck. And you want to remove as much tumor as you can. At the same time, you don't want to damage the spinal cord. So it's a delicate balance of trying to get everything out. So just move things along. So we removed it, 4 screws above, 4 screws below. Just so you know, the next day she was walking around after doing this. People do extremely well. And just Murrow's classification is a classification we use for long bones, or the femur, basically, is when do you do surgery? So it just gives the numbers, and 3 points for the side of the lesion. So the trochanter gets 3 points, the most points. The larger the size cortex, the larger the lesion, more likely you should do surgery, get more points. The appearance, if it's lytic, you get 3 points, and if the patient has a lot of functional disability, you get 3 points. And if you're a 9 and above, you need to fix it. So her lesser troch, if we put her in this criteria, she's a lesser troch, so she gets 3 for that. It was a small lesion, so she only gets 1 for that, so 4. The appearance was lytic, so she gets 3, so that's 7. And she had severe functional disability, she gets another 3, so that puts her at 10. So she should fix it. So the point that Miro made is not all these lesions need surgery, which ones do, and he felt that this was his criteria. And it's been studied many times. It's a very good baseline if you don't know what to do. Yeah, Mr. David, Dr.
Yeah.
David.
What about the actual attachment of the tumor to the cord? What did
Mhm.
you do there?
I peeled it off.
I mean, it came off. It wasn't
It came off.
invasive for the cord. Growing.
Well,
into
it was on the
cord?
dura. It was on the dura.
Oh,
So I had to peel it off the dura. It was very difficult. I'm just complaining. That's all. But it's hard. But I'm sure I left microscopic disease.
sure.
But at the same time, you want to remove as much as you can because they can recur. So those are the issues. You want to remove as much to avoid recurrence, and yet you don't want to damage the spinal cord. That would be horrible.
But how often do you get that nice a situation where it doesn't cross the dura? It usually doesn't.
Oh, the
cross
dura is
the
a protective membrane. I don't know
It
why.
Usually, really doesn't. Oh,
It's extremely rare. I don't know why the dura is protective. No idea. So the other thing is, when do you do the hip surgery? She can't walk because of this pain. So I don't know if you guys have any opinions. I just said 48 hours. I didn't want to do it at the same time because it would have been a very long anesthesia, blood loss. And yet I don't want this woman laying in bed for that long. And it's best to get it all done all at once. So I don't know if you guys have any opinions. I have no idea, but I just said 48 hours because I felt in 48 hours all the fluid shifts should be basically balanced. If she's going to have any severe complications in the spinal surgery, we would know it by then. And mentally, I think 2 days is not too long of suffering to wait for another surgery. So it went perfectly. She had the hip surgery 2 days later, and she improved very quickly. Okay, so now I
didn't make those drawings, actually. That was Leonardo da Vinci.
that was Leonardo da Vinci. I thought that was on your spare time,
Yeah.
on your doodling. So Dr. Dixon's going to take over. So just tell me when to turn over.
Okay, next. I'm going to stand up and use my high-tech pointer here. Is that
Oh,
okay?
we have
Yeah.
we have a laser pointer for
Okay.
you. Unless you want the exercise. It's the top button.
Okay. So in pathology, blue is bad. Blue is bad because the stain that we use to stain the tissues, the hematoxylin, the blue stain, stains the nucleus, and the eosin stains the pink, and that's the cytoplasm. And in tumors, you get a very high NC ratio. You get the ratio of the nucleus to the cytoplasm becomes very high, so you see more nucleus than cytoplasm. So often in benign tissues, you have a lot more pink, whereas in malignant tumors, you have more blue, just because the ratio of the nucleus to the cytoplasm is very high. So blue is bad. And I say that because I saw, this case come across my desk, and I just saw the slides without even putting it under the microscope, and it was very, very blue. So I knew something blue from the spinal cord is probably not very good. So under the microscope, what you see is a lot of blue, and you see a lot of blue because it is a very high NC ratio of these cells. This is a malignant tumor. The other thing you notice is that it's forming glands. So you can see these kind of primitive gland formations. You don't see it all around, but you see enough that makes you think that this is an adenocarcinoma. Next.
Can I interrupt you, ask you one question?
Mhm.
Is there any chance that this could be a primary sarcoma that looks like adenocarcinoma? Is that in any way possible?
At this point, it's poorly differentiated, okay? So you kind of everything's in the differential, but when you see the gland formation, that would be very, very unusual to have a primary have good gland formation like that. Now, if you had areas that were just like this, and some of the tumor just looked like this, where you only get a very vague hint of maybe a gland forming here and there, this could kind of be anything. You can get sarcomas that mimic carcinomas, absolutely. Um, but in this case, you have the gland formation, and again, very helpful that we had the history, so we're kind of knowing which path to go down. So again, this field shows, again, these cells with a very high NC ratio. And you also notice that from cell to cell, the nucleus looks a little different. It's pleomorphic. So again, that's the typical finding, especially in high-grade tumors, that the nucleus from cell to cell is quite different. Next. This is just another area showing there's a little bit of matrix kind of going along with this tumor. This is the pink. And again, you see a gland there, you see a gland there, and you see a gland there. And in endometrial adenocarcinoma, that's what you get. You get gland formation like this. But you can get it in adenocarcinoma of the colon, of the salivary gland. There's many, many things that form glands. So you have to kind of start to narrow down what you're dealing with here. Next. This just shows you the tumor within bone. So this is actually bone here. This is how bone stains pink, and you can see kind of the lamellar lines there. But this just shows you the tumor is like infiltrating all through the bone there. So there was a lot of soft tissue that you gave me, but then there was also bone, and there's clearly tumor within the bone. Next. So then we start to work it up to see exactly what we're dealing with. So one of the first things that we do is do a keratin stain. So you think of keratin carcinoma. So many, many carcinomas stain with keratin. And that's very helpful kind of in the whole differential of carcinoma, sarcoma, melanoma, lymphoma. Those are kind of the four branches of the tree that you want to go down. So in this case, the carcinoma stain, the keratin stain is very, very strong. But again, many, many things are positive for keratin. Next. So a very helpful thing is that the keratin stain was positive, but then the vimentin stain was also positive. So vimentin stains basically mesenchymal cells, fibroblasts. It stains sarcomas. But this is a tumor that's staining for both, and that's actually quite unusual in the body to have something that stains both with keratin and vimentin. Endometrium is one of them. You mentioned renal cell. That's actually another one that stains both with a carcinoma stain and a sarcoma stain, or keratin and vimentin. Other ones are salivary gland, thyroid, but there's not many, and so it's very helpful when you have both keratin and vimentin staining in a tumor.
What is the vimentin staining?
So it's basically, it's almost like an aberrant stain. And normally, again, it stains kind of mesenchymal cells, but for whatever reason, in those tumors that I mentioned, even though they're carcinomas, they're staining with the carcinoma stain, the keratin, but they're also staining with vimentin. The exact mechanism, I'm not sure exactly why it decides to stain with that. So, next. So at this point, you know, you've kind of narrowed things down because not many things stain both with keratin and with vimentin. So this is the estrogen receptor stain. And again, most, at least well to moderately differentiated adenocarcinomas of the endometrium stain with estrogen and progesterone. This stained with both. So this is very strongly estrogen positive. You can see it's staining the nuclei of the cell. So this is very strongly estrogen positive. Again, it's helping you narrow things down. Renal cell obviously wouldn't do this. Other things that might stain with estrogen include breast. But again, breast wouldn't stain for vimentin. Breast could look like this, but you wouldn't have keratin, vimentin, and estrogen stain. Next. And this is one of the other stains we did. This is P16. Now, P16 is actually a marker that we use to identify HPV-infected cells. So cervical carcinoma often has, or almost always has, HPV infection associated with it. And as you may have heard, we're getting more and more oropharyngeal cancers, especially in men, that are P16 positive, that are actually related to HPV infection. So there's a very big increase in men that have oral carcinomas that are HPV positive. Now in this case, this is not indicating HPV infection. You see it's not staining all the cells, it's kind of patchy. If it was very strongly and diffusely positive, you would think maybe this is coming from the endocervix, because most endocervical cancers are HPV or P16 positive, strongly positive. This is patchy positivity. It's a different mechanism, but the P16 gene is kind of deregulated in adenocarcinoma of the endometrium. So this is just another kind of like another piece of another clue that this is adenocarcinoma of the endometrium. Vimentin positive, keratin positive, estrogen positive, patchy P16 positivity, and all that is consistent with an adenocarcinoma of the endometrium. Next. And that's it.
But does this pinpoint HPV as being an etiological
Yeah,
factor?
half of them have HPV, it looked like, though. Why?
Right. So it's a different mechanism. So P16 is a tumor suppressor gene, basically. What HPV does, it has these two parts of the genome, E6 and E7, that mess up the regulation of P16 in the cells of the cervix. So HPV can affect P16, but P16 can also be deregulated in other tumors, and in adenocarcinoma of the endometrium is one of them. So it's a surrogate marker for HPV infection. In the right context, it means HPV infection, but in other contexts, it just means that the P16 gene has been deregulated, and that's what's happening in adenocarcinoma of the endometrium.
Huh.
So that's what we do in pathology to figure out that
Very
it
nice.
looks like it's adenocarcinoma of the endometrium.
Very nice. Does anybody have any questions for Dr. Dixon? Okay, so we're going to finish up soon. So just a couple of statistics is most common cancer of the genital tract in developed countries is endometrial carcinoma, but for developing countries it's cervical cancer. And the incidence is highest in the U.S., lowest in India and Japan. It's usually 60-year-old women. It's the fourth most common malignancy in women. I think metastasis, distant metastasis is not that common. More common like local adjacent metastasis. So just as one final thing is when do you need to instrument spinal tumors? And just like you have a scoring criteria for the femur, there's now a scoring criteria for the spine. And it's called the SINS score, Spinal Instability Neoplastic Score. And the score gives points for the location. So let's do our patient. So our location was T12. Now T12 is a junctional location. There's a lot of stress at the thoracolumbar junction because the ribs make it stiff, the lumbar spine's mobile, so you get a lot of points. It's a high risk area, so you get 3 for that. Mechanical or pain, so if patients have no pain whatsoever, basically it's not as bad as if they have a lot of pain, and the pain is a marker for instability, abnormal motion. So she had a lot of pain, so that's another 3, so she has 6. Aaron, can you keep track of how many points we have? 6. So then the bone lesion quality, what would you guys describe it, the lesion? Huh? Anybody? Remember the CAT scan? Very lytic, right? So unlike like a blastic, maybe some breast or prostate, those are very stable tumors, but this was very lytic. So you get another 2. So what are we up to now? 8. So the alignment If there's subluxation or deformity or kyphosis, you get 4 points. Did she have any of that? She's pretty normal, wasn't she? Yeah, so she doesn't get anything for that. So collapse, if you get less than 50%, if you have no collapse, you get no points. And she had, how much collapse? She had about 25%, didn't she? I think she had 50.
I don't think it was 50.
Yeah, so less than 50. So that puts her where, 2?
10.
10. And posterior involvement, bilateral, what's that?
Unilaterally.
So how many did I give her? 11?
11.
So that puts her in the potentially unstable category. So
Didn't talk about any spinal cord compression.
it didn't. It was just stability. The other thing this does not do is neurological status, and usually most of these things put neurological status into the form or whatever. I'm surprised. I mean, this is just a tool that what we have, and so that's the last slide. So this is just a tool, and basically, as a physician, if someone's not walking, that's a serious problem. So that, for me, pushes them into surgery a lot more likely, because I know in these cases, and I'm not sure Dr. David doesn't believe us that she walked the next day, but she walked the next day, you remember?
But not with her. She walked the day after her.
Her hip was
surgery.
fixed, but she walked
Right.
my point is she walked very quickly.
Yes.
Just in my experience, and I'm not saying it because I'm a surgeon, is these metastatic pathologic fractures walk very quickly.
Yes, and because Dr. Antonides goes and gets them out of bed, unhooks everything, sets every alarm off, and walks them down the
Right.
hall and leaves them
Right.
3 doors down.
Right,
They walk.
well, no, that's really important. It's serious. I learned this as a fellow. Is my fellowship director said you have to go yourself, get up there, take all the IVs off, get the patient out of bed, grab them, pull them up out of bed, and walk them yourself, do a lap around. And he said, there's a reason. He said, no one's going to do it. You're the only person who's going to do this. Everyone's afraid. Everyone's worried about the patient. Also, the first day, the patient has extreme amount of pain. And by doing that, you give the patient the confidence, like, I'm fine. And if the doctor does it, then I can do this. And then
And the patient won't do it for anyone else.
They will not.
They
No
refuse
one.
to do it for me, and he walks in and they jump out of bed.
they just because they have the confidence in you because you have all this knowledge, and they say, and they get up and do it. And everyone's angry at me, right? That I'm doing this. What are you moving the patient? What's going? So it's very important, and nobody else will, but you do it. So I have you do it sometimes. Did you walk? And if Erin goes, no, she wouldn't move. I was like, all right, let's go. So I go upstairs and I walk by myself.
Better results than the evangelists.
No, well, that's seriously like the power of positive thinking is very powerful. So they walk right away. So if someone's not walking, I give that a lot of points that they need the surgery will help, and also it stabilizes the fracture. So when you have a fracture, it's extremely any kind of motion is extremely painful, and once you fix it, they feel, believe it or not, they feel better than before because now their spine is immobile. But I didn't use that criteria, but sometimes I do it. So any other questions about? Yeah.
There's got to be a certain number of patients that's too late, isn't it? It's too late that they
For
get
surgery?
surgery or medical care. They've already got compression of their spinal
Right.
cord, and their paralysis or neurosymptoms are permanent.
Right. Well, the Patchell study that did look at that, in that there's a much higher probability that you will walk if you have the surgery than if you don't. But you're right. I mean, there are some cases that obviously there's really nothing to be done. That maybe patients have a massive amount of tumor in many places, ill, malnutrition. So you have to use common sense too.
And she had, what happened to her uterus?
We already had a hysterectomy.
Yeah,
Oh, I see.
I don't think there was any tumor there
Okay.
in the CAT scan. So there's no local recurrent tumor. It was all just metastatic.
But histologically, this looks as though she
Well, we have the expert here.
What was the question? I'm sorry.
Did this definitely come from the uterus? So there's no question.
Yeah, there was one stain I didn't even show that was the P10 stain, and that's quite specific for adenocarcinoma of the endometrium. So again, none of these things are 100%. You always remember none of these immunostains are 100%. But when you put it all together, there's always all pieces of the puzzle. When you've got 4 or 5 stains that are all consistent with it, we did other stains that ruled out other possibilities, and then with the history, that's what it is.
So when did she have the hysterectomy?
She had a hysterectomy a year ago.
Okay. And they didn't report anything? Or they did?
Report metastasis at the time?
On the path report, in the uterus? On the hysterectomy?
A year ago.
Yeah, did it show a tumor?
Oh, yeah. She
Oh, I
had,
see,
she had
okay.
stage 2. She had stage 2 cancer at the
Okay,
time.
sorry, I
Yeah.
missed that.
Yeah, you came in a little late. Yeah, I'm sorry. I forgot to fill you in.
My other question is, why is everybody wearing an orange shirt in this picture?
Well, I think humans, we have this need to belong to groups. It's this tribal tendency that we have. It's very, very powerful.
Is it?
Yeah.
A better
And
question is, why aren't there more orange shirts
They're
than
probably-
green seats?
they're probably playing the Yankees because we have a lot of Yankee fans. But we have this strong tendency to wear, and you see it all the time now. Like all the teams, everyone has a color shirt.
I'm a foreigner, I just needed to know, go
We,
outside.
hey, they do that. They do it in your country. There's a strong feeling to belong. To look a
It's probably
color.
worldwide.
Oh, your
yes.
football club.
Yeah,
Yeah.
they
We
wear
know
the.
you like the Tottenham Hotspurs.
Yes.
You wear a
Do you have a
jersey and you
shirt?
belong.
Do you have a Hotspurs t-shirt?
Yeah. Any other questions? Okay.
Nice case.
Thank you.
Thank you.
very
Thank
much.
you everyone for coming.